Hey, it's Steve Kronlage here to talk to you about tennis elbow, or otherwise known as lateral epicondylitis. So, lateral epicondylitis is extremely common. It's the most common elbow affliction. 2% of the population is affected at any time. It's usually between 35 and 65 years old, or mostly between the fourth and fifth decade. It's more common in men than women. The original condition was coined in 1883 due to lawn tennis. This was when they used clunky wooden rackets. This is a modern tennis racket with a vibration dampener. These usually don't cause tennis elbow unless the patient has a poor swing. Most tennis elbow occurs in patients not playing tennis. They're doing other things, working 12, 14 hours a day, and probably not exercising as much as they should. So patients with tennis elbow often say that they don't know when it started hurting. It just got worse over time or it had an insidious onset. The pain is laterally at the elbow, right at the bump. They'll have diminished grip strength. They'll say, I can't pick something up. It happens whenever I'm picking a jug of milk up, trying to move a chair, trying to position my arm in space. Often they'll relate an actual incident or some trauma that they think caused this. The pathology in tennis elbow or lateral epicondylitis is poorly understood. It's thought to be a result of repetitive microtrauma, but the patient has to be susceptible to this. We do know that it's at the insertion of the extensor carpi radialis brevis tendon. That tendon goes from the elbow to the wrist. It holds the wrist in extension, and so that we can get a better grip. This is why patients have pain with grip, because we have to stabilize the wrist in extension for power grip. Try flexing your wrist and gripping something. You have no power. So if the tendon is torn at the elbow or is hurt at the elbow, anytime you try and do power grip or lift things, pick a jug of milk out from the refrigerator or pick up a chair, you'll have pain at the elbow. And people complain of weakness. It's important to remember that this is not an inflammatory tendonitis. It's actually a tendinosis. There is no inflammation on the pathology slides taken from specimens from the surgery. So for physical examination of lateral epicondylitis or tennis elbow, patients have pain on the bump on the outside of their elbow, just anterior to the lateral epicondyle. The lateral epicondyle is the bump. There will be pain with resisted wrist extension. Hold the wrist in extension and push against it. There will be significant pain. The pain will be at the elbow when that happens. It will not be at the wrist when that happens, right here. There'll also be pain if you passively flex the wrist, also at the elbow. This is putting stress on the muscle. In addition to that, patients will show a reduced grip strength, and this grip strength will be worse when the elbow is extended. There are other causes of lateral elbow pain. The most common cause is radial neuritis. This is where the radial nerve or the posterior osseous nerve goes underneath the supinator muscle. It gets compressed here and causes pain. This can occur sometimes with lateral epicondylitis, sometimes without. The presence of this needs to be found out while treating patients. In addition to this, if there's a significant injury to the elbow, the lateral ligaments can be torn as well. It's important to check this. This is very difficult to examine for, so MRIs are essential in finding lateral ligament tears. X-rays are usually normal on lateral epicondylitis patients. Sometimes there's a spur or calcifications directly over the lateral epicondyle. Ultrasound can be done in the physician's office and can definitely show a tear in the ECRB that shows up as a hypoechoic region and is usually obvious. An MRI can see a tear, and it also can show frank muscle detachment and retraction, and is definitely helpful in surgical planning. If one looks online for tennis elbow or lateral epicondylitis, they'll find more treatments than can be quantified on 5 slides. But these are the most commonly used treatments would be bracing or taping, therapy, steroid injections, needling, dry needling or causing irritation to the tendon insertion, blood or blood product injections, Botox injections, laser therapy, shockwave therapy, surgical treatment, whether it's a percutaneous release, a debridement and a repair, or an arthroscopic surgery. There's tissue debridement, 10X procedures, and there's also denervation, which is taking the nerve, cutting it, and so that the patients don't have pain. It's enough to make you very confused. We do know what's bad for tennis elbow. We do know that steroid injections can give relief short term, but long term, it goes away. Steroid injections can cause significant subcutaneous atrophy and also atrophy of the muscle. This can cause the muscle to rupture. A single steroid injection has shown that a 14% chance of greater poor outcome and a 77% chance at a re-injury within 1 year relative to placebo, which means that 3/4 of all people with one steroid injection should have a re-injury within a year. I see many patients that have had multiple steroid injections. We can use different things to inject around the elbow, blood or PRP. We're not really sure where we are with this, but we found that it's safe and there are some good results. But non-surgical treatment really is confusing. We found that there is really no intermediate or long-term clinical benefit of non-surgical treatment compared to observation, which is even more confusing. So who needs surgery for tennis elbow? This is a study out of Barnes-Jewish in St. Louis. They found that out of 580 patients they treated for tennis elbow, 16% required surgery. And they boiled it down to predictors for surgery with an odds ratio from highest to lowest. The number one reason, or the most patients they had that needed surgery, was workers' comp. Secondarily was prior steroid injections, then presence of radial tunnel syndrome, and those that had had a previous successful orthopedic surgery. And lastly, patients that had symptoms for more than 12 months. So surgical treatment for tennis elbow is best done a year out from symptoms because most patients will have gotten better by then. It can be done percutaneously with a small needle or a knife. It can be done open. Most doctors do a small debridement and repair, especially if the tendon is retracted on MRI. And it can also be done arthroscopically as well. There has not been any method proven to be better or worse. So with tennis elbow, do we do something or do we do nothing? It's important that patients know that they're not damaging themselves further from not treating this surgically. Doing anything is most likely the same as doing nothing. We do know that steroid injections are the only thing that's proven to be harmful. Many patients want to do something. Many patients are in significant pain, so they want to have some sort of treatment. And that's why we work on therapy and aggressive exercise treatments for these patients. Surgery does work, but the patient should have the final say, and it should be at least close to a year before surgical intervention is undertaken. Remember that lateral epicondylitis is a pain phenomenon. Most patients get better despite what we do. There is absolutely no harm in waiting for surgical treatment. Steroids, once again, hopefully you've gotten this point through, can cause significant problems. Many different treatments work, and surgery is effective if it is needed. Thank you.